So today we have a really special presentation. I will say that this presentation was born out of discussions that happened maybe 4 to 6 weeks ago, or a little longer, when I, kept being asked in hallways or would have side discussions about, a lot of angst, I think, that physicians were feeling as boosters were becoming a thing about whether it was ethical or appropriate to be desiring personal boosters for those of us all vaccinated months ago, at the same time that we were aware of the global needs for vaccine. And in fact, of course, the WHO had at that point put out a statement to stop requesting that countries like ours stop rolling out boosters through the end of the year. And so from those conversations and from that angst, this session was born. And I think I didn't expect at the time that, in fact, this would become such an important week for this discussion. With, as you guys all know, the FDA VRBPAC meeting earlier discussing who qualifies for boosters in the United States, but also the expected announcement by the Biden administration during the UN meeting to purchase 500 million more doses of vaccine to donate to the world. And so I'm super excited to have a really impressive group of experts to help us think through this quandary. So to introduce our guests, I'll start with Dr. Nicole Lurie, who is Director of CEDPI US and Strategic Advisor to the CEO at CEDPI, which is the Coalition for Epidemic Preparedness Innovations, for those of you guys who are not aware. She's also Senior Lecturer at Harvard Medical School, a member of the research faculty at MGH, and a Professor of Medicine at George Washington. She served an 8-year term as Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services, and in that role led the HHS response to numerous public health emergencies, ranging from infectious disease to natural and man-made disasters, and is responsible for many innovations in emergency preparedness and response. She also chaired the Public Health Emergency Medical Countermeasures Enterprise, which is a government-wide organization responsible for the development of medical countermeasures, including vaccines against pandemics and emerging threats. She, before that, had a long history in health services research. I won't detail all of that, but included time at the RAND Corporation, the University of Minnesota, Minnesota Department of Public Health, as well as other roles at HHS. She's a graduate of the University of Pennsylvania, completed residency in public health training at UCLA, and is a member of the National Academy of Medicine, as are all of our guests this afternoon. So I think it's actually really special that we have 3 members of the National Academy of Medicine presenting at Emory Grand Rounds. Following Dr. Lurie is Dr. Wachter, who I thank you for coming back to be at Emory Grand Rounds again. The last time we invited you, I asked you not to speak about COVID-19, and really your conversations about this exact topic led me to ask Carlos and others if we could maybe get you back in a COVID-19 role. So Dr. Wachter is Professor and Chair of the Department of Medicine at the University of California, San Francisco. He is the author of 300 articles in the medical literature, as well as others in the Times, the Post, USA Today, the Wall Street Journal. He coined the term hospitalist in 1996 and is considered the father of the hospitalist field, which is the fastest growing medical specialty in US history. He's written several books, including The Digital Doctor, Hope, Hype, and Harm at the Dawn of Medicine's Computer Age, which was central to what your previous Grand Rounds topic was about. And has been selected as the most influential physician in the US in 2015, has won the top honor in patient safety, the Eisenberg Award in 2004, and as I mentioned, is a member of the National Academy of Medicine. This past pandemic, though, Dr. Wachter has become a really trusted source of information on clinical public health and policy issues surrounding the pandemic, with a very active Twitter account viewed more than 250 million times and counting. And I'm really grateful for your contributions today. Moderating our session and contributing to our session will be someone known to all of us, Dr. Carlos Del Rio, who is Distinguished Professor of Medicine in the Division of Infectious Disease here at Emory and is Executive Associate Dean for Emory at Grady. He is, as you all know, also a Professor of Global Health in the Department of Global Health and a Professor of Epidemiology at Rollins. I won't speak too long about all of Carlos's accomplishments because I think, again, it is known to all of us. But he too is a member of the National Academy of Medicine, and with Dr. Lurie has been co-chairing webinars, really discussing the exact topics that we're discussing today. So Carlos, I will turn it to you to take over our session.
Thank you, Wendy. Well, as you mentioned, this is a really important topic. I mean, boosters have really heated up, and there's a lot of discussion about them, about how they protect us, what do we need to do, but also the issue of health equity. It reminds me every day, you know, you wake up and you hear what % of the global population has been vaccinated. You hear now that there's going to be a UN summit in which the president is going to be talking about these issues. So this is obviously front and center to the COVID vaccine debate. And the COVID debate, because at the end of the day, if we don't vaccinate the world, we're never going to end this pandemic. So I couldn't think of anybody better than Dr. Lurie to tell us about this. She has worked incessantly on this issue from the very beginning, and really is some of the most thoughtful persons thinking about this issue. So Nikki, please start.
Good. Well, thanks so much, and wonderful to join everybody here, and even to see some old friends on the screen. And let's see if we can make my slides advance, which would be wonderful. So just thought I would start and talk to you a little bit about, where are we now and how on earth did we get here anyway? And then maybe propose some ideas about how to get to a better place. So where are we now in the race to vaccinate the world? These statistics were current as of yesterday. So close to 43% of the world's population has received one dose, which is absolutely staggering. 5.9 billion doses have been administered globally. Again, totally staggering. But if you think about, the world is on the one hand doing great, on the other hand, the world is doing horribly. 1.9%, less than 2% of people in low-income countries have received at least one dose. So how on earth did we get here? Well, there are a number of good stories about how we got here, and some challenging ones. But I think how we got here in some sense started with a whole series of actions after the 2014-15 West Africa Ebola outbreak, when the world tried to say never again. And after that, a whole host of activities kicked off. WHO created a bunch of blueprints for action. The Global Health Security Agenda, which is a huge program to strengthen country capabilities around the world, kicked into action. A number of task forces talked about what to do. A global pandemic monitoring board was set up to pay more attention to what happens in the next pandemic. One of the other things that happened is CEDPI, the Coalition for Epidemic Preparedness Innovations, was created. And CEDPI is an international organization that was created by about 9 different countries, the Gates Foundation and the Wellcome Trust. And I will say, until recently, not the US, with a goal of developing vaccines for potentially epidemic diseases, if any occurred. And there were a series of diseases on that list that included Lassa fever and Nipah and Rift Valley fever, and importantly, MERS. One thing to understand, and I'm not going to ask you to really digest this busy slide, but to say in the US, for product development for all kinds of infectious diseases and for managing a pandemic, there's more or less a system. And if you look on the column for the US responsible funder, you can see everything there's filled in. Somebody's responsible for developing diagnostics and therapeutics and vaccines and buying them and distributing them. We can argue about how well they do, but somebody's responsible. In the global system, look at all those nones. There is nobody responsible for almost any of this. CEPI was just formed. It was 2 years old when COVID started. So CEPI, being very young when COVID started, decided to act fast and on the basis of very imperfect data. So we all know now that we got early warnings of this thing in late December with all kinds of rumors coming out of China, and then notification of 12 cases of strange pneumonia. Well, by the first week in January, I think it was clear that this had the potential to be a global crisis. And so 3 days before the sequence was posted, CEPI convened its emergency response team, called the developers that were working on platform technologies and MERS vaccines and said, we understand this is likely to be a novel coronavirus. When the sequence is posted, will you please get started? And by the 23rd of January, had announced a series of partnerships. And you can march from left to right on this slide, and you can see that in January and February, we developed a pretty robust portfolio of vaccines. And although NIAID began work with Moderna at the same time, it's important to note that the US government couldn't figure out how to put money in this beginning. And Operation Warp Speed began in earnest April 29th. Think about what could have happened if Operation Warp Speed had begun in earnest at about the same time CEPI started or shortly thereafter. So round about March, as we were working on vaccine development, we woke up one day and said, you know what? There is no global system to do an awful lot of stuff that needs to be done. It'll be great to develop a vaccine and even prove that it works. But is there enough capacity, manufacturing capacity in the world? We did some surveys and decided there was, but there was nobody to pay for that manufacturing capacity. Nobody to make reservations, nobody to buy raw materials. We all know Operation Warp Speed decided that they were going to manufacture doses of vaccine before anybody knew they were going to work, but there wasn't a global system to do that. And so pretty much we had to create one. CEPI stepped in and made a whole bunch of investments that you can see on this slide. But ultimately, with recognition that there was no global system, something called the Access to COVID Tools, or ACT Accelerator, was established to recognize the need for speed, scale, and access, not just for vaccines, but for diagnostics, for therapeutics, for oxygen, and for other kinds of equipment. And something called COVAX, which you've probably heard about now, is the vaccine pillar of that ACT Accelerator. That's now a partnership between CEPI, Gavi, which is the Global Vaccines Alliance that purchases childhood immunizations for low-income countries around the world, WHO, and UNICEF. And it started with an original goal of saying, let's vaccinate 20% of the world, and let's be sure that there's enough vaccine to vaccinate 20% of populations around the world, and to do this equitably. That basically was what it would take to cover healthcare workers and high-risk adults. 190 participating economies joined COVAX. And CEPI, through its development contracts, basically secured the right of first refusal to over 1 billion doses of vaccines. So when it made all those initial contracts, they said part of the deal is you sell to us first before you can sell to anybody else, and we will designate an access agency to give those doses to. That became COVAX. And delivery got started early in the first half of 2021, and then things kind of stalled out. So just to be clear, it's, as you can tell, it's not just the R&D developing a vaccine, but from this COVAX perspective, what else has to happen? Well, all the countries have to decide that they want to sign up. It was quite a process. The countries all need to get themselves ready. There needs to be some kind of a plan and readiness assessment to be sure that if you actually deliver vaccine to a country, that they could handle it. And that includes regulatory approval. And importantly, a really huge thing has been liability coverage. No vaccine manufacturer would ship vaccine anywhere in the world without liability coverage. And so we created a system of indemnification and a no-fault compensation fund for the 92 poorest countries in the world. Then you have to figure out how much vaccine is going where, especially with all the different kinds of vaccines. You need to release it, you need to get it to a country, and then not shown on the slide. Once you deliver it in a country, it actually has to go that last mile and get in people's arms. So where are we now? This slide, again, current as of yesterday, just shows us countries that have gotten vaccine for 100 doses. And just look at these countries on the list. A bunch of high-income countries have gotten a lot of vaccine. Bahrain, Israel, Chile, the UK. The US is down there. We've got a lot more vaccine, obviously, than has been administered, but these are doses given to people. Look third from the bottom at the rest of the world. And look at India with this gigantic population that's actually doing quite a good job vaccinating their country in many respects. The bar graph belies what's really going on. Take a look at this. This again shows that same data on a map, and look at Africa, look at Eastern Europe, look at some countries in the Middle East, look even at some countries still in Latin America. You can see there are gigantic vaccine inequities, and we have a long, long way to go. Even if you could take almost all these African countries, put them together, and they still would not have received as many doses as any high-income country. So this is a real problem, and you can imagine that lots of people around the world are screaming bloody murder. I don't know how much we hear it on this side of the Atlantic. Last week, very distressingly, COVAX updated supply forecast for this last quarter, and basically said it was going to miss its commitments by 25%. This was accompanied by, as Dr. Armstrong said, yet another plea by the WHO for people to hold off on boosters until the world was vaccinated, and to have sort of a moratorium at least till the end of September. What on earth happened? Let's just go really quickly through this. At the beginning, at the same time COVAX was being formed, all the high-income countries of the world made their own bilateral deals with manufacturers. And as you can see from these slides, bought way more than they possibly could have needed. So everything above that green line is basically over ordering or over purchasing. And they did that because nobody knew in the beginning what vaccines would be successful and which ones weren't. But then you see tons of countries that made bilateral deals also to the right. Then it turned out there's a huge shortage of raw materials. Typically in a year, the world produces 5 billion doses of vaccine. This year, it's going to produce 14 billion. So there weren't enough raw materials, and the US Defense Production Act really made it so that the US got served, but other countries did not. Manufacturers were overly rosy. And then a number of countries, the US to some extent, India and South Africa blocked vaccine exports of vaccines, and COVAX was really dependent on the Serum Institute of India to deliver vaccines to the world, and India has blocked vaccines. They said today or yesterday that they will unblock them next month. A lot of countries, including the US, have said they ordered too much and they're going to donate them. But boy, the lag is many, many months. And even if you wanted to share them, there are incredibly restrictive provisions between the manufacturers and the countries that limit their use, how they can be used, and where they can be used. So what needs to happen now? COVAX is still passing the tin cup to be able to buy enough vaccines for the world. Can't do that. You can't pass the tin cup in the middle of a pandemic. We need to unblock these exports. We need to manage this global dose supply now so that doses aren't wasted. Right now, there's 150 million stockpiled doses in the US, and we're trying to convince people to get vaccinated. I'm not sure all those 150 million doses right now need to be sitting in the US. There are better ways to manage the supply, and that's the case across Europe and many other places. So expediting this dose donation, helping with delivery. And then Bob's going to talk about this controversy about boosters, but let's at least balance high-income country desires for third doses and the responsibility of sovereign leaders to take care of their populations with the need to vaccinate the world and get ahead of more variants. And then finally, we could talk about it in the Q&A. In the US, people are now clamoring for single dose vials. There's not enough glass in the world to put it all in single dose vials. It cuts the vaccine availability by about 40%. Happy to talk about why. So for goodness sakes, if we're going to give people boosters, let's hold off on single dose vials until the world is vaccinated. We said never again once before. How can we say it again? I mean, how can we say it and really mean it this time? So I've just put on this last slide a couple of thoughts, including systematically reducing the risk of naturally occurring threats. We hear a lot about that in the climate change discussion as well. Be sure that the political will is there to invest in health security and in the revolution in vaccinology. Be sure that there's an end-to-end financing system so that what we ran into in CEDPI and with COVAX and why it all got formed never has to happen again. As I said, passing the tin cup in the midst of a crisis never works very well. Thanks.
Thank you, Nikki. That was absolutely terrific. We're going to go ahead and now have Bob do his presentation, and then we'll have a discussion. So Bob, go ahead.
Great. Thanks, Carlos, and thanks, Nikki and Wendy. It's great to be here. I'm actually in Atlanta by coincidence, down in Midtown. My son works for the Braves, and my daughter-in-law works for the CDC. So it's actually very nice to be in town. And I noticed that your COVID rate is down to about the national average, which is good because it was not a couple of weeks ago. Let me see if I can share my screen. There we go. All right, hope you can see that fine. Nikki's setup was perfect because I think Nikki has pointed out sort of the issues, a lot of the issues around global distribution, and the glass vials remind me of the early days where we were looking for nasal swabs. It's sort of it's the thing that you don't even think about that gets you, and clearly vaccinating the globe is an important and critical goal. But I'm going to talk about the debate over boosters. My sense early on in the debate, which started a couple of months ago, was that we were talking about it as if it was all about numbers and efficacy curves. And yet I think it's actually far more complicated and far more interesting than that. And that's what I want to spend a few minutes with you talking about today. Before I start all my talks these days, it's been such a brutal last 18 months that I like to check in with people. And as I think I did last time, I use the Fauci scale. So these are 5 pictures of Dr. Fauci's face during 5, I think 4 of them, 2 through 5, were probably in 2020. I think number 1 might have been this year. And I'll give myself a Fauci 1.8. And that's admittedly focusing on our world in San Francisco, where we had a little bit of a surge, but cases have come down by about 2/3. Cases in my hospital have come down by half. And we're about 75% of all of the people that live in San Francisco have received a full vaccination. So we're well ahead of the national average. And I think that is helping us beat back too bad a surge. So here is kind of my main point, which is I think that particularly for lay people, when you hear the booster debate, there's a subtext that most people don't understand. And for folks like me that have been in healthcare forever and have thought a little bit about ethics and trade-offs and resources and all that, it feels actually like an age-old debate, but it has some unique twists. And so let me kind of take you through the outlines of that debate. There's one way of seeing the world, and that is to focus on the needs and the desires of individuals. And by this way of, if you look at healthcare through this lens, you say the goal of healthcare is to maximize the outcomes for patients. That makes sense. We assess risks and benefits of a given intervention, might be a test or a treatment, and we recommend it when the benefits outweigh the risks. And societal considerations, such as the cost of the intervention or scarcity or others that might benefit, are really for others to grapple with. There was an influential article in the New England Journal in the 80s that was called The Doctor's Master. And it made the argument that the doctor's master can and should only be the patient at the bedside. Now, the doctor might leave the bedside and go to a meeting of the medical staff of a hospital or a national or regional organization, at which place the doctor, same person, but might don a different hat and begin thinking about societal or communal needs. But at the bedside, the patient needs to trust that your only focus is on him or her, not on society's needs. And of course, health insurance, usually less than it used to, but usually insulates patients from overweighing the cost of the interventions. And so the idea is to create an environment where the doctor and the patient are both thinking about what's best for the patient. And if that sounds familiar to you, you're probably a physician, because this is how we are socialized. My daughter is a 4th-year med student at my place now, and it's been fun watching her go from layperson to physician, which is essentially what happens during medical school. And physicians are clearly socialized, maybe a little less so now, because it's much more thinking about society and social good. But I think by and large, physicians are socialized to think about that individual patient. That, of course, is abetted by the malpractice system. Society doesn't sue you for using its resources. Patients may if you don't. and patient autonomy, which is a huge value in the United States, and that is fed and amplified by the media and social media. When there's harm to an individual, we hear about it through a variety of mechanisms. So that's one way of thinking about the world. There's another way of thinking about the world that says we care about populations of people, and that too much focus on the individual leaves out the needs of others who are not at the bedside but are equally important. Trade-offs are inevitable, lest you have what's called the tragedy of the commons, that you're focusing on each of the individuals, but you don't have enough for society. The example is of a field for grazing, where everybody takes what they want. Eventually, the field doesn't have enough resources, grass for everybody. And so this way of viewing the world says we need to weigh the risks and benefits for the individual, but also think about them through a societal lens. And if you take, if this is the lens you see the world through, you say to use a scarce resource for a marginal individual benefit when its use in other ways could benefit more people more is fundamentally unethical. Now, if that sounds like a familiar way of thinking about the world, that's how public health professionals are socialized. And it leads them to tend to focus on things like clean water, nutrition, and on things like vaccines, things that we're talking about giving out to huge numbers of people or trying to improve for huge numbers of people. And we focus less on risks and benefits for an individual and more at the aggregate level. So that's really how doctors think about the world. That's how public health professionals think about the world. Obviously, I'm simplifying the world. Both groups are smart enough to understand the other perspective. But these, I think, are two very different ways of thinking about the world. And important to say from the outset that I don't think either argument is more right than the other. They're both important ways of lenses to see the world of health and healthcare, but there is a tension between them because often there are trade-offs, and often the answer you would come to if you were looking at the individual perspective is different than an answer you might come to if you were looking at an aggregate perspective. So a lot of the debate about boosters has really been very numerical and statistical and framed by statisticians examining Israeli vaccine efficacy curves like you see here. But I think that it's actually about this individual aggregate perspective. Let me give you what I think is my quick and dirty summary of the research. You may disagree with parts of it. This is my distillation of a whole lot of papers that new ones come out every day. But I think there's a general consensus on most of these. Most data are, of course, from other countries because A, they vaccinated earlier, and B, they're better at this than we are. So the data that Israel has, for example, is just terrific and better than we have because all of the patients in Israel are in a computerized system. They're in one of 4 HMOs, and pretty easy for them to figure out the efficacy of vaccines and how they might or might not be waning over time. Far easier for them than it is for us in the US. But here's what we know. The efficacy versus symptomatic or mild COVID has waned a lot. Now, whether it's gone from 95% to 60 or 70 or 75 or 50 is up for debate, and the statistics and epidemiology are a little complicated because of confounding, but I don't think there's much debate that it has waned a lot. And as more time goes by, there's more waning. It seems worse for Pfizer than Moderna, but there's far less data on Moderna. And J&J has been essentially a black box, although there's some data that came out today about second shots that are promising in terms of creating more durable immunity for J&J, still to be confirmed. The efficacy against severe, and by severe we generally mean severe enough to send someone to the hospital, the ICU, or to kill them. Efficacy against severe COVID has waned, but has waned less. And there are some studies that would say it hasn't waned at all, but if you remember the early studies that came out saying that the vaccines were essentially 100% protective against hospitalization and death, nobody thinks that anymore because there are many, many cases of people who have been hospitalized with breakthroughs, and in fact, hundreds of cases, actually probably thousands of people who have died with breakthrough infection. So it's no longer 99%, whether it's 95, 90, or 80 is up for debate, but it's not what it was. It's clearly enough to increase the risk, particularly in those at higher risk to begin with, largely the elderly and those with comorbidities. I don't think there's much debate on the fact that boosters will restore immunity to about the level, maybe better than where you were after your second shot. at minuscule risk, no greater risk than the prior shots you got, and at least to the individual, zero cost. And what does restoration of immunity mean? Certainly restoration of immune markers such as antibody levels, but also epidemiologic and empirical studies showing that there are fewer mild and fewer severe cases. At least the data from Israel shows that. How long will that last? I'd say that's completely unknown. I get asked that all the time by reporters, and I say how long anything lasts in COVID is how long we've studied it. And there are so many surprises and curveballs. So my thesis is that the argument here is more about what I showed you earlier, which is the individual versus societal perspective, than it is about disagreements with anything that I've said above on this slide. We can talk about that in the Q&A, and maybe there are some disagreements, but even folks that are pushing back against the need for boosters in high-risk groups will generally acknowledge that most of, or all of what I've said above is true, although there might be some differences in terms of some of the statistics. Okay, let's spend a minute talking about sort of ethics and resource allocation. First point, resource allocation choices and trade-offs are inevitable. I like this quote from Engelhardt and Rhee, two medical ethicists, from an article about 30 years ago. Humans have the aspirations of deities, though never the resources. So we always have to make choices. And more pithily and musically, you can't always get what you want, per the Rolling Stone. So the idea that we have to make trade-offs is embedded in the act of delivering healthcare. So let me show you the way I think about this. And this sort of comes from more economic literature than medical literature. And it says that intensive therapy, let's say for cancer, heart attacks, migraines, diabetes, you name your favorite disease, COPD, in many things in life, and it's not just true in healthcare, it's true in most of our purchases, the benefits you get from initial costs and to some extent some risks go up very fast. And then they tend to flatten over time as you might be spending more and more money, and you may be getting more and more benefit per unit money spent, but the amount of benefit you get is less than you got for the first amount of money. So think about this outside of healthcare. The cup of coffee you get at Dunkin' Donuts gives you benefit. If somebody could go on mute. Looks like Jennifer, thank you. The benefit you got from your cup of coffee at Dunkin' Donuts for whatever that is, $1.50, gives you the benefits of a cup of coffee and the caffeine. But this morning I went to Starbucks to get mine because the extra benefits of my tall mocha from Starbucks give me more, but it was a lot more money. If I bought a really cheap car, the benefit of it getting me from point A to point B safely is good. If to go and spend an extra $50,000 on a Tesla probably doesn't get me from point A to point B any better or faster or safer than the Yugo, but it does it in more style and the computers are spiffier. And so that's sort of flat part of the curve. And that's what the economists talk about when we think about marginal benefit. So in medicine, the basic treatment you get tends to yield a lot of benefit. That's aspirin for your MI or basic treatment of hypertension or your cholesterol, let's say. And in medicine, in many cases, there's then fancier treatment. There's immunotherapy for cancer. That's some newfangled migraine drug. There's some new diabetes medicine. And it typically, let's say it does work, it delivers more benefit, but the extra cost is quite large. So the amount of benefit we got from that extra cost is what we often debate in American medicine. And the economists call that the marginal or incremental benefit. And so in America, in a rich country, in developed countries, this is often where we're operating at that part of the curve where if you're in a developing country, the question is often, can you deliver clean water? But in a wealthy country, it's often, is it worth the extra benefit? We talk about the new Alzheimer's drug or some of the new treatments for cancer. Yes, they're beneficial, but is the benefit worth the extra cost? And the question is what you would do with the money if you didn't spend it on that. So this is the way I kind of think about the world. The interesting part of this curve in medicine is where that question mark is. And the poor clinician needs help because that's an open question, what to do there. If you were taking the individual perspective, which physicians find quite comfortable, you would do that thing because you notice the curve is upsloping. The benefits outweigh the risks, and the cost is not to be considered because it's free or relatively inexpensive to patients because of insurance, so you should do this. You would even do that. You would even do that as long as the curve is upsloping as a physician, your job is to recommend it. You'd only not do that because the curve is sloping downward, meaning there's net harm. If you looked at the world through a societal perspective, you would say doing what's at that question mark is not right, because you shouldn't do that until you fully funded and you're absolutely doing for everybody stuff that's on the better part, on the higher slope of the benefit to risk or benefit to cost curve. So you want to do that and that before you said, all right, we now have enough resources to do what's at the question mark. So this is sort of the way I frame this debate, and I think about a lot of healthcare seen through this lens. Now, vaccination is a particularly interesting case for these reasons. Some resources are mostly about money, so we talk about chemotherapy or MRIs. Others are truly limited, and you have to make tough resource allocation choices like liver transplants. Vaccines are somewhere in between. They're, as you've heard from Nikki, some of it is about the money, and some of it is about whether it's truly scarce. Contagious diseases add another interesting twist because the treatment for an individual has an impact on others. Not true when we talk about treatment for cancer or diabetes or emphysema. And it's not only local others, not only treatment for you decreases the chance of you spreading it to somebody in Atlanta, but also at some level it's national and global in terms of both spread and the possibility of variants. So the issues of how to handle the flat part of the curve, I find more nuanced and multi-layered than they are from many other things we think about in healthcare. So with that in mind, let's spend a minute or two looking at some of the arguments. This is the domestic edition. I'll turn to the global edition in a second. We should be concentrating on vaccinating the unvaccinated. I love this one because I hear it and I scratch my head. Because first of all, as Nikki pointed out, there's no shortage of vaccine in the United States. So it's not like giving a booster to one person means there's not a vaccine available to the person in somewhere else that wants it. And when I hear it, it's not clear to me what else we should be doing or how foregoing boosters would help. You see on the bottom, Governor Newsom of my state with the lottery, where we gave enrolled people in a lottery if they were vaccinated. You can get a free spin around Talladega racetrack. In the NFL, if you're a player and you don't get vaccinated and your team has an outbreak, you forfeit the game. All of the players lose their pay that week, so you have 100 275-pound people who want to kill you. So it seems like I'm not sure what that means, concentrating on vaccinating the unvaccinated. It feels like we're already doing that. I hear giving boosters will send the wrong signal to the unvaccinated. At this point, to me, it's not obvious that any signal will help. We've tried pretty much everything. Now we're trying mandates. And I could argue either side equally. I think boosters may dissuade some when they see that, people need a third shot, or seeing more breakthrough infections may dissuade others to say, look, the vaccines don't work. And in the absence of data, this seems like a wash to me. And finally, I hear periodically the vaccines weren't designed to prevent mild infection. I have to say, I don't really care what they were designed for. If they used to prevent, quote, mild infection, and now they don't, and a booster can reestablish that protection at essentially zero risk and zero cost, then personally, I want that. Also, we hear a lot about, well, as long as they prevent severe infections, that's all we care about, and mild infections aren't bad, it's just like a cold. And that obviously is not true. Mild infections can be like a cold. They can also be like you feel like you were run over by a bus for a week, or you can't taste or smell for a month. And we don't know the percentage of breakthrough infections that lead to long COVID, but it's not zero. It might be as high as 10 to 20% in one study from Israel. And of course, mild infection can spread to others. We know that breakthrough infections can spread to others now. So there is an argument to give people boosters, if only for the public health benefit of spread in terms of local spread. The more interesting arguments, I think, are the global arguments, and they're really tricky and fascinating and push a lot of hot buttons. So let me sort of focus on a couple of them. First question I ask, is the global vaccine equity argument, and I don't mean the argument in general, in some ways the way Nikki framed it, which is, of course, there is an argument to vaccinate everybody, but is that, as we think about trading off boosters, is that a humanitarian argument or a pragmatic, self-serving one? If it's a humanitarian argument, like how can we give people boosters for a benefit in the US when we're not doing it for people in India or Africa, or and people haven't gotten their first shots? Why is that different in a fundamental way than our treatment for cancer, heart attack, diabetes, stroke, almost everything in the US we treat differently than the treatments that people have in other countries. And you can make an argument that that's wrong, but we don't really spend a lot of time debating whether giving immunotherapy to somebody today at Emory is inhumane or unethical because someone in Indonesia is not going to get immunotherapy. It's just baked into the way we practice. So then I hear, okay, no, it's not really a humanitarian argument. It's a pragmatic argument that we have a self-interest in vaccinating the world. I get that in a way, but I'm a 63-year-old guy who got my 2 shots of Pfizer 8 months ago, have not gotten my booster yet. And if you ask me which one is going to protect me more, my 3rd shot or sending that shot to some unknown, unnamed place, so in the hopes that that will prevent another nastier variant than Delta, that at the end of the day will make me safer. I don't buy that. I think if you focused on pragmatic grounds, I would take my booster today. Again, sort of putting aside the ethical arguments there. Logistics and contracts, is it realistic to send the booster that's waiting for me in my local Walgreens or CVS abroad? I didn't hear that from Nikki, although I'd be interested in exploring that. Individual versus societal perspective. Is it reasonable to expect any nation's citizens to forego individual benefit in the name of global equity? You might say, of course it is, but I don't know any countries that would do that. If they truly believe that their individuals are going to be harmed and some will die because they're foregoing something that is here right now in the name of sending it abroad, doing that for humanitarian grounds, that's a lot to ask of a country. And then you have the issue of scale and trade-offs. When the global need is 5 to 10 billion doses, would the 100 or so million doses that we would need to boost immunocompromised healthcare workers, teachers, and people over 60 in the US truly make a material difference, or is it symbolic? And I sort of come down, this feels a little facile, but I think it's really not an or, it's an and. And the way I frame it, this is my last slide, is to go back to the benefits versus cost curve. Absolutely vaccinating people who are unvaccinated in the US and globally, huge benefit, little cost, little risk. We should do everything possible to do it within reason. But also giving a 3rd shot to immunocompromised people, giving a 3rd shot to people with an elevated risk of a bad outcome or exposure, healthcare workers, teachers, and probably people over about age 60. And then you get to the general public. To me, that is such a flat part of the curve, a healthy 30-year-old, that at this point it's not a high priority. And as it turns out, most of them haven't hit 6 months yet anyway. We'll know more about them over the next few months. So to me, the individual perspective says the benefits outweigh the risks and costs for these groups, which is why I favor boosters in these groups. I don't think the benefits are large enough now to generally give boosters to everyone, but I think it could easily be true that we should over the next few months, and we'll learn more in the coming months. And here is the and. I think there's obviously a huge benefit to vaccinating unvaccinated people in the US and globally, and we should find the resources, but I don't think they can come at the cost of doing what is beneficial and where the benefits outweigh the harms to individuals in terms of giving out boosters to the groups that I have in that middle square. So with that, let me quit and look forward to the discussion, and thanks for the opportunity to speak to you today.
Thanks, Bob. This was absolutely terrific. I think we really have set the stage for this debate and this conundrum. So I think I want to start with just asking a question about, frequently people say, should we send, to poor countries the vaccines left over unused in the US before they go bad? Does it make sense to do it? And if this is a good idea, how do we do it? How does it happen? Since the vaccines have already gone to the States, and the States, it's really not the US doing it. It's more like the States have to do it. What is the process there, Nikki?
Sure. So I can maybe start to tangle that. It is a good idea if in fact they're not going to expire before they can get somewhere. I think, and the issue really has to do with a whole bunch of contractual language saying that if US bought them, they can only be used in the US and they can only be used for a public health campaign. By the way, they can't be used for additional clinical trials. And so lots of developers around the world who are now trying to get their phase 3 trials going can't get access to comparator vaccines because all the contracts are written in such a restrictive way. So the process would have to be You have to get them back from the States. There are all kinds of issues about chain of custody and liability at every step of the way. You have to get them somewhere, and you have to know that where you're getting them can use them in time, all of which is a complicated series of processes. It probably at this point, if we're really sitting on 150 million doses, would be far easier to move some of those doses to other countries now and backfill those $150 million with doses that, Pfizer or Moderna or anybody else are gonna manufacture now, because there's no way in my mind on God's green earth that we're gonna burn through 150 million doses in the next month. And so I think the both and means that we could release more doses now. The problem is that's not what's happening. The problem is, even with this commitment to purchase doses for the world, deliveries are months down the road or in 2022 or whatever. And so if they were really serious about doing that, we just need to accelerate. But the government and many governments signed contracts that were exceedingly restrictive, including in different market territories, so you can't give them to another country. That's the basic problem, Carlos.
Excellent point. Wendy, you want to take over?
Sure. Dr. Stevens, I see that you have your hand up. Go ahead and unmute and ask your question.
Great. Can you hear me? First, I want to thank both of you for really excellent points, excellent presentations. I have really two questions. One is just to really follow up on the point you just made, Nikki, about the contracts and how limited those contracts or the limitations around those contracts have really tied our hands to some degree or to a great degree. And can we, can we unravel those contracts? That may prove to be not possible in order to get these doses out there. And two, can we really not allow this to happen in the future? Because I think this is has really, from my perspective anyway, tied our hands, and we're going to be wasting doses of vaccine that could be used elsewhere. So that's one question. And then my other question really is about the term boosters. And I'm not convinced that immunologically that 3 doses isn't the right proper initial regimen, given what happens after the third dose. And there's all this debate, as I think you're aware, between, what is that right interval between the first and second dose? And so I think there's a lot of immunology here that we don't fully understand, and we get into this term of boosters when maybe it's a primary series, and maybe we're going to be, as you suggest, Bob, impacting transmission in a major way which could be incredibly powerful as a tool to control the pandemic. So those are a couple of questions. And again, thank you very much.
Great. Well, I'll jump in, and then Bob, you might also want to say something about the third dose issue. But I guess my own view of this is where there's a will, there's a way. And it is legally complex, but the United States has a huge amount of clout and purchasing power. And it's hard for me to believe, when it's spending this much money on Pfizer and Moderna and J&J vaccines, that it can't find a way to do this. Early on, it found a creative solution by lending vaccines to Mexico and then getting paid back. And a number of countries have found those to be pretty creative solutions. I think there are an array of solutions, and I certainly hope that we've learned a lesson and will never happen again. What I would say, to give you a little bit of optimism, was that in H1N1, it took about 9 months to resolve the legal and liability issues of sending doses from the US to anywhere else. This time, mindful of that, we all got together and put together a liability indemnification scheme. And as I mentioned, a no-fault compensation scheme, a vaccine injury compensation fund for low-income countries, so that by the time the rollout started, liability was no longer a concern. I can't say the pharmaceutical industry was super helpful, but at the end of the day, they accepted that. So it does tell me that the world can learn. Just to complicate your third dose thing before I send this to Bob, I think there are tons of questions about this primary series versus booster, and what is the right time for our primary series versus booster. But complicating that also are a lot of a number of studies and some suggestions that if you actually give a second or third dose of a different vaccine on a different platform, you might actually even more broadly protect against variants. So there are lots of questions about what is the best vaccination strategy overall, and what's the best vaccine policy overall, and a research agenda for that. I think the jury's out. It's interesting, again, in the US, funded narrowly a couple of studies based on the needs in the US. We have Sinopharm, for example, that tons of people around the world have gotten. It's not a very effective vaccine. We need to think about, should we give a second or third or fourth dose of something else to make it a lot better? CEDPI will be funding those studies because there's no one else to do it. Over.
Yeah. Oh, so there are layers and layers and layers of complexity here. I think in the pragmatic, sort of the here and now, which is of course the only sort of world we can live in today, the trade-off of, do I want to wait, not to be too narcissistic, but let me take me as a sort of paradigmatic sort of 60-ish-year-old person sort of waiting for a shot. Do I want to, people have made the argument that it's in my self-interest to wait, because 2 months from now, we may understand that rather than getting a third dose of Pfizer, I should get Moderna, or rather than getting a third dose of regular Pfizer, I should get rejiggered anti-Delta Pfizer. All possible. I still would take it today if somebody offered it to me. The issue of, is it a booster or a third dose, I think is really fascinating, but to me lives more under the heading of marketing at this point than under the heading of science. Yeah, and I think you're right, David, that if we could look back on where we are now, we might say that it's logical to believe that 2 doses given 3 weeks apart would not be sufficient and not create enough durable immunity, because we know that from other vaccines that you want to wait longer. But when we were vaccinating people in the middle of a surge in the winter, it was reasonable to try to get dose 2 in as quickly as possible and feasible. And so at this point, I think when we say, well, let's not call it a booster, let's call it your primary series, it sort of feels like we're doing a little bit of hand waving to not, because the word booster is so loaded. The idea that how can you boost someone without this other person getting their first shot? I think I think at the end of the day, it probably will turn out that the second shot was so soon that there is actual value, and the correct series is 2 shots fairly far apart. But for now, it feels more like a response to the sort of ethical and public relations pickle that we've found ourselves in, rather than almost a distinction without a true difference. And I'd say that the 150 million dose issue is really interesting. I can't imagine that we will run out of them, because but if somehow all of the mandates actually kick in, and we now can vaccinate all of the kids, and we're allowing boosters for at least high-risk groups, it's a fair number of vaccines that we're going to want to give out for a period of time. And politically, it would be disastrous for the administration to run out. I think with 150 million, we're not going to run. I'm not worried about that. But let's say it was 50 million, you were making the same argument. There is a possibility that with all of the new groups coming online, you don't even want to cut it close politically, because that would be a terrible political blow, at least for the administration, to not have enough.
Thank you.
All right. Let me ask, Dr. Lyon asked, should we consider the economic benefit of preventing mild disease, i.e. not missing 2 weeks of work, in our decision regarding boosters, and even losing healthcare workforce with staffing and so on in that decision making?
I would say, the answer is yes. In some ways, that is a more societal benefit that we should be weighing as we make all of these decisions. And if you took that seriously and you said our goal was to improve health and healthcare domestically, you might very well say that even though the argument for personal health benefit begins to wane as you get to younger, healthier populations, the societal benefit to try to keep the workforce intact is actually quite high. So you're sort of looking at not just the benefit to the individual in terms of their own personal health, but lowering the probability of spread. And that might lead you to draw a different line and not say the line is at age 60 or 65. And in some ways we're doing that when we say, well, we're also going to include healthcare workers and include teachers. The FDA sort of recommended healthcare workers and was a little bit wishy-washy about teachers. But I imagine at the end of the day, we'll probably end up recommending both. And it's hard to say that a healthy 30-year-old physician or nurse is a high risk of a bad outcome. So what's the justification to give it to them? It's a societal benefit, is that they are exposed to an enriched sample of COVID patients, and they are also exposing people at high risk of a bad outcome, older people and immunocompromised people, and the society has an interest in keeping that workforce intact. And so we're already getting into some of the other groups where the issue is more social than individual, and I think we're kind of embracing that because the needs seem quite strong.
Thank you. Shifting back to the global questions, two questions. Is the rate limiting step for vaccinating the world the number of doses or the logistics and need for a cold chain, part one? And part two is, you talk about fully funding COVAX. And I guess for me, as a person interested in HIV, I watched the Global Fund for TB, AIDS, and Malaria struggle along forever. Is this how is COVAX funded? Is this a worldwide commitment? Is this mostly a U.S. commitment? And how difficult will it be to really get it fully funded from upper income countries?
Great. So in answer to the first question, the rate limiting step has been the number of doses that are available and when. The cold chain is a pain in the neck. It's expensive, but I think starting with Ebola, the world figured out how to deal with it, and they are dealing with it. Some countries have chosen not to accept Pfizer vaccine, but get a different vaccine because the cold chain's easier, or because there's always a cost share and because it's cheaper. But the rate limiting step is clearly the number of vaccines that are available. And it's fair to say that most vaccines that are sent to a country have been getting used, or a country says we can't use them and they get reallocated to another country quite quickly. In terms of money, remember that there was no financing system for any of this at the beginning. There was no system to say to a manufacturer, if you make vaccine, we'll buy it. And there was no system to buy doses for COVAX. So countries had to donate money to COVAX and also to the Accelerator, for the Global Fund for Diagnostics, for therapeutics, for whatever. And it has all been based on country donations. The US super slow to donate until the change in administration. And now, a lot of the donation now has come in the form of, buying Pfizer vaccine for the world and providing some cash. I think $750 million that will be ultimately to help with sort of delivery and administration on the ground. But there is still a substantial shortfall, and all these countries have had to buy doses for themselves, then buy doses for the world. The World Bank has lent money, as it usually does, to low-income countries. Low-income countries have either pooled their money and bought doses through the African Union, or pooling their money and buying doses through COVAX, because then they get the liability protection and other benefits from that. But it's a doses and money issue.
Yeah, I think you're right. I think this is really a very important, interesting discussion. I do think that the global response really right now is, I would say, stuck. And I think we need a quantum leap in the level of global ambition to end this pandemic. I am sort of hoping that at the upcoming UN meeting, when the president speaks, really they ignite a process with clear goals and targets, something very similar to UNGAS, for example. I think we need the U.S. to step up and provide global leadership. I think the global response really right now is leaderless. And whether there needs to be a UN special envoy, whether it needs to be somebody who coordinates this, and we have to get the U.S. and the global dose sharing to go where it needs to go, because otherwise we're just, and we also need to work with countries in distribution and delivery capacity. I think, to hear about countries where the vaccines get stuck in loading docks and don't make it to people, I think it's a problem, and we need to work with the logistics of getting that into people. But I think we clearly have, the U.S. clearly has a role to play here that I think we should not miss that opportunity. On the booster front, I think that increasingly, I believe, Bob, I mean, I think boosters will be required, and I'm very much like your graph about who to give it to and how to prioritize and how to make that decision, right? And it may be that, I think the concern that I have is that it's more an issue of crowding out, and we haven't talked about this, but it's crowding out vaccination sites with people who want boosters. And I tell people that you may have a bunch of people wanting to get vaccinated, only have extra capacity in our clinic to vaccinate people. And then the people that want to get vaccinated, who haven't been vaccinated, will not have a slot or will not be able to come in. And just like the issue that Nikki talked about with glass, I think there's also an issue with global needle and syringe availability. At some point in time, we will have problems running into not having enough needles and syringes to give this vaccine. So that's a lot of issues really that need to be looked at. And I think we still haven't resolved this. But I want to say thank you to both of you. This has been a terrific discussion, and I really appreciate your time being with us. And we look forward to hearing more from you into the future.
And thank you both so much.
Thanks very much. Appreciate it.